Hey everyone, so this starts module 2, which is focused on ligamentous injuries. So we're going to introduce ligaments at this in this particular presentation, and so that you guys have kind of this basic background that we did with cartilage. So we'll do this at the beginning for each of these different modules. So I want to talk about ligaments today, recognizing that ligaments are pretty similar in their composition to tendons. So when we talk about tendons for the next module, Paul will do that, and you're going to see that a lot of these things are pretty similar, and they react pretty similarly to stress and strain and those kinds of things, but their healing is a little bit different. So what I want you guys to be aware of is when we're talking about ligaments, we're talking about a connective tissue, okay? It's a dense connective tissue. It's very fibrous. It's basically there to connect, as I'm hoping you already know, bone to bone. And so we have two different kinds, and I say that it's connecting bone to bone. That's the skeletal kind, and that's the kind that we're going to be focusing on. But also recognize that there are visceral ligaments, and these actually are ligaments that connect organs. So they basically are there to kind of connect the large intestine to small intestine, the large intestine to itself, that kind of thing. Composition, as I said earlier, it's going to look similar to a tendon. It has a lot of water. 2/3 of the ligament's weight is water. And in terms of the dry weight, there's basically 70% is collagen. So it's also a large amount of collagen, and it's primarily type 1 collagen. And we'll get into that as we talk about the healing process, because what you're going to see is that we can't develop type 1 collagen very well. And so that's becomes sort of an issue when we're talking about healing. There's also a little bit of elastin, which sounds just like what it does. It allows for some elasticity or stretching of the ligament, and that's 1 to 2% of the weight, the dry weight of the ligament. So I'm not going to go into a lot of detail. You guys, it's not really that relevant to know all of the anatomy, the microanatomy essentially, but just recognize that the collagen is the primary dry weight, and that we want those fibers to be organized parallel to each other. And so you can see the picture here and how the ligament attaches to a bone, and you can see again those long collagen fibers that are gonna go in a certain direction. And with ligaments, we do have that elastin, and so it becomes a little bit more wavy. So they allow for those wavy fibers to then stretch out. That's what the elastin does, so that we have the ability to stretch ligaments with movement. At the bone, you have two different ways that the ligament can attach, and so we have a direct and indirect. Direct attachments tend to be more along the epiphyses and the apophyses. So those basically have superficial fibers that attach to the periosteum, and then there's also deep fibers that basically go at a right angle to the bone. So if you think of the ligaments that you see in like the carpal bones in the wrist, those tend to be direct, and they literally go directly into the bone at a right angle. Whereas the indirect, which are more common in things like long bones, so our femur, humerus, those kinds of things, those are going to be indirect, and so they have sort of a superficial layer that's more oblique to the periosteum. So it's going to sit kind of along the periosteum obliquely. And then there's also these deep layers of fiber that anchor to the bone via what are called Sharpie fibers. So basically you need to recognize that the indirect are going to be following more the line of the bone. And again, these are mostly in long bones, whereas the direct is going to go more at that right angle to the bone. Most important thing to be aware of, just like with cartilage, is we need to understand the vascularity. We need to understand how blood flow occurs, and we also need to understand nerves related to the ligaments. Unfortunately, ligaments do not have good blood flow, so they are also hypovascular, especially the ones that are intra-articular. And our intra-articular ligaments are going to be things like the ACL. And so what you're seeing here in this picture is an ACL, and you can see that there's this, the end of the ACL that's attached to the bone has some blood vessels. That picture is showing it, as well as some nerve. So there's blood vessel and nerve right at the attachment to the bone, but then as you go up into the ACL, and this is an ACL that's been grafted. So they've grafted the original ACL to a graft of some kind, and we'll talk about those different options here in a minute. And you can see that there's a lot less blood flow and a lot less nerve endings where the graft is. There are mechanoreceptors, so those are the nerve endings we're talking about, in ligaments, and so that's really important that we recognize that the proprioception and things happen, and our ligaments can sort of recognize that. So basically what we are finding is that you do have some blood flow that's close to the bone. As different ligaments get grafted, then we will see the ability to provide a little bit of blood flow, and a little bit of nerve, but it's not going to be as good as it was with the original. So we have what's called the stress-strain curve that we think about when we think about the ligament biomechanics. And I'm not going to go into a lot of detail about this. You can see the picture here. And basically what it means is we have that elastic ability of the ligament, that basically viscoelastic behavior, and that's basically allowing the collagen, the elastin, the proteoglycans, which we're not going to talk about, and water to basically allow for the ligament to stretch. While it's stretching, there's an increased number of fibers that get recruited to allow for the tensioning to occur. And then you have those wavy fibers that we talked about. The collagen or the elastin is kind of wavy, and that those kind of straighten out as you add more tension. So as you get this first part here of the stress strain curve, you have a lot of elongation occurring. And so you have a lot of pulling that allows for stretch. And then as you get closer to kind of the end range of the ligament being able to stretch, then we add more tension. So again, more fibers are recruited to allow more tension to occur so that we don't end up tearing, which is essentially what happens here at the end of that stress strain curve in the picture. So normal low load activities, so basically things like walking and stuff, we get good elongation of the ligament. As we get into higher loads, then this is where we recruit more fibers and we get stiffness. So that stiffness, unfortunately, can then cause tears. And what's interesting is you stretch the ligament for a longer period of time, like 30 to 40 seconds, and it actually decreases the stress. So I can put ligaments on higher load stress and keep it there for a while, and it actually, the ligament itself will become less tense, essentially. As we get older, what we also find is that ligaments change. And so they have decreased elastic stiffness. They have that elastin has decreased. The collagen content also increases. And so this basically makes our ligaments more rigid. So if you look at the stress strain curve between a 35-year-old and a 75-year-old, the ability for the ligament to fail or tear is much higher in a young person and than it is in an older person. So I think a good example of this is when you think about an ankle injury. So as a younger person, most of the time, when you roll your ankle, you're going to sprain or tear the ligaments. When you're older and you do the same movement, you actually end up fracturing your bones because the ligaments are so much stiffer that they don't stretch and tear. They actually end up pulling on the bone and causing bone fractures. So you're going to see a lot more ankle fractures in older people and a lot more ankle sprains in younger people because of the change in that ligament. So what causes these injuries? Again, that example of the ankle sprain, it's going to be some sort of macro trauma. So something that's happening at high force. This is a very, very sad looking picture of this ankle sprain. And we can grade our ankle sprains or any type of ligament injury as a grade 1, 2, or 3. Grade 1 being a mild sprain, no disruption to the ligament. Grade 2 being what we would call a moderate sprain. And so there are fibers that have been torn, but the ligament itself is intact. So that's what we call basically a partial tear of a ligament. And then we have grade 3, which is a complete disruption of the ligament. So the ligament is torn straight through. The process of healing for ligaments, this should look somewhat familiar. We talked about time frames with the different types of tissue. And what we can recognize is that the time frame for a ligament is anywhere from 1 to 2 years, actually, with the inflammatory process being first. Not terribly surprising. It's going to last for 48 to 72 hours. And this is kind of where, if there was tears, those ligaments are going to kind of retract or pull back. And then the repair phase lasts for about 6 weeks. And so this is where we have the fibroblasts proliferating, meaning we're getting more and more of them. And that's going to make an extracellular matrix. So it's going to make a nice little place for the collagen fibers to come in. And so the fibrin clot happens first, and then type 1 collagen fibers come in and start to develop the ligament again. What's interesting about ligaments, unfortunately, the collagen fibers don't tend to lay down straight. So even though we have this extracellular matrix that in theory can help put the collagen fibers in the right place, oftentimes they're not going to line up in those nice lines like what we had in the original ligament. And so what we can do to help as physical therapists is actually perform range of motion exercises during these first phases to help allow for the matrix formation to be better. So it allows for better orientation of the collagen fibers. And so we need to do very gentle range of motion during these first phases in hopes that we can help to make that ligament a little bit more similar to the original ligament. If you push it too hard, obviously this is going to lead to more tears. And so you're going to basically decrease or slow down the healing process. So you have to be careful about how much you're doing. But as I said earlier, you have this 12-month process of ligament healing. Maturation and remodeling phase starts after about 6 weeks. And this is where we're trying to get nice collagen fiber alignment. Unfortunately, what they find is even after 12 months, when in theory everything is healed, you definitely still have fibers that are not lined up very well. And so this does make this ligament a weaker tissue than it was originally before the tear. So remember that even though in theory these things have been healed, they're not going to have the same tensile strength. They're not going to be able to follow that stress strain curve the same way that they did before the tear. So as I said earlier, we have intra-articular ligaments, extra-articular ligaments. Intra-articular ligaments mean that it's actually, again, within the joint. So the best example of that is going to be an ACL. They basically say that these are going to have less blood flow, so they're going to have less ability to heal as well as extra-articular ligaments. So things like an MCL or an LCL, again, after about 6 weeks, especially if it's a partial tear or a grade 2 tear, you can go back to normal activity. But ACLs, even at a year, you'll see that they have load failure of 63 to 73% maximum load failure. So meaning that they're probably not, their stress, again, that stress strain curve, the stress on them is going to be very, very significant, significantly decreased. They're not going to be able to take on the same amount of strain. Partial ACL tears, however, in humans, they've done research and found that as long as you have some ACL, so again, it's not a grade 3, but more of a grade 1 or 2, if you have some of it on an MRI, which is not the case in the picture below, then you can have healing done. And again, that's because we do have some blood flow at the proximal and distal areas of the ligament where it attaches to the bone. So there is going to be better healing than if there is a full tear. There's not going to be any healing if there's a full tear. So when we talk about ligament repairs, oftentimes we're going to be introducing something into that area for the repair. So again, they're not going to usually try to stitch the ligament together because they recognize that the blood flow isn't good enough to allow for healing. So instead, what they're doing is they're bringing in what are called autografts or allografts. So autografts, the most common ones that you're going to see are, again, with the ACL. And the most common one is either a patellar tendon graft, so they're taking the tendon from the patella and actually using that like ligament, or a semitendinosus or hamstring graft. And when we talk about ACLs, we're going to talk about the fact that patellar tendon grafts heal much more slowly because we actually have taken away the patellar tendon compared to a hamstring graft, because hamstrings tend to be pretty strong, and we don't tend to have as much of an issue with healing a hamstring as we do with healing a quad. So the outcomes generally tend to be better. What they do is they usually will kind of overlap these tendons to make a new ligament. So they'll like double it up, triple it up, that kind of thing, so that they have more strength when they insert them. It's really important that you guys understand the healing and the time frame for healing of these ligaments. So again, most of the research that we have for ligament healing occurs with ACLs, and it occurs in animals. So that's important that you're aware of the animal part of it, but also recognize that we can really compare this to humans as well. And we think these timeframes are pretty similar. So by the 4th week following an autograft, you should start, the synovial membrane should start to envelop the graft. So that synovial fluid, remember we've talked about this with cartilage, is important to get nutrients and things like that to the ligament. By 6 weeks, it should be completely enveloped with that synovial membrane, which is good. That means we're getting the things there that need to allow it to heal. But that's at 6 weeks. So you really need to keep that in mind. Recognize that there's nothing really happening to that foreign body that is a tendon stepping in for a ligament until 6 weeks, because we don't have synovial fluid getting to the ligament itself. By 8 to 10 weeks, we start to see blood vessels, okay? So that's still 10 weeks that we're starting to get blood flow, okay? And then by 20 weeks, we should have complete vascularization. So that's still, again, that's 5 months, guys. So really think about that. Think about the fact that there's no blood flow getting to that ligament until 5 months later. Or there is blood flow, but the full blood flow doesn't occur until 5 weeks later. So that's a long time. And we want to make sure our patients understand that when they're coming in and doing these grafts, it's not really part of their body as a ligament until 5 months. But even at 18 months, what they notice is that this is finally when it starts to look like an ACL. So that's a year and a half later, guys. Like, that's a long time. And so we're going to talk a lot about return to sport with ACL injuries, because it's so important that people recognize that ligament is not truly their new ligament, their ACL ligament, or it could be something at the ankle, whatever, until 18 months. And that's a long time. And obviously a lot of people return to sport way before 18 months. So keep in mind that this is all this that's happening, and there's nothing we can do to change this time frame, okay? So patients will be like, yeah, but I really trained well and blah, blah, blah. It doesn't matter. They have to go through the process of tissue healing. And that's something that's important for them to understand for any of these tissues that we're talking about through these classes. So this is kind of a cool picture. This is a hamstring graft here. And you can see sort of the normal healing process in this picture. And what this image is showing is where you can start to see the blood flow start to get in there. So the first one is at 12th month. So you can see that ACL is starting to look like an ACL, basically at 12 months. So we're starting to get blood flow, which is good to see. But again, 12 months. So sorry, that the ACL on the left is at 6 months, and the one on the right is at 12 months. And basically what you can see is that looks more normal than the one on the left, which is at 6 months. So allografts are using tissue from a cadaver, and I don't think that people really do this in China, because I think it's like considered like not culturally appropriate. But they do this in China. They do this in the United States and in the West. Usually we do an allograft if it's a revision, so they don't want to, of course, start cutting up your tendons again if you've torn your ACL again following surgery. So these are people who have had a repair initially with an autograft, and the autograft didn't take, and so now they're coming in and using other tissue. So they might choose to do an allograft. And this is basically, like I said, where they're taking the tissue from a dead body. So these don't happen a lot in China. They may not happen at all. I don't really know. I haven't seen any. But they say that they take a little bit longer for healing time than an autograft would. What I have seen a good number of in China is a synthetic, is these synthetic ligaments. This has become a lot more common, and I've seen at least a dozen of them here. So I don't think anybody really knows how long it takes for that to incorporate into the body, but we treat it like an autograft. So that same time frame that we talked about is kind of what we need to follow. So again, the idea is that by 18 months, it should be incorporated, but we need to move more slowly, because at 5 months is finally when they get their blood flow. So just keep that in mind. As we get more research, hopefully we'll be able to show you more of this stuff. I'm not going to go into detail about this research. This research literally just came out this month, in May of 2020. And it basically compares those three things. I'll go into more detail when we talk about ACL, but recognize, like I said earlier, that the autograft from the hamstring or an allograft from a cadaver healed much more quickly, and return to sport happened much more quickly than patients who used patellar tendon. So again, it has a lot to do with quad strength and being able to get the quad stronger faster for patients who have a hamstring autograft or an allograft than if you have a patellar tendon autograft. So we'll we'll talk about that more when we talk about ACL. So what can we use for decreasing irritability when we have something like an ankle sprain, which you kind of see in the picture there? So what they found is that using cold, I know nobody likes to use cold in China, but using cold does help to decrease irritability and allows for you to return to your ADLs more quickly than if you use heat. So as much as patients here love to use heat on everything, I have to really encourage them to either use nothing or use cold if they're not totally adverse to it. Also using things like interferential current, electric stimulation, will decrease pain and swelling compared to a placebo at 24 hours after surgery. So modalities do help, and especially cold and things like electric stimulation help with pain control. But immobilization, not good. So this is the kind of thing that we sort of talked about with cartilage. I think it's even more important with ligament healing and tendon healing and bone healing. We need to load these different tissues. So we need to find ways to do that and not immobilize these patients for long periods of time. There's so much research to show how bad it is. Most of the research is done on animals, but what they found is that if you immobilize a ligament, that we actually change the makeup of that ligament. So they don't have that same elastic property that they should. The entire structure changes. And that obviously is not a good thing. So what they found is that if, when they looked at rabbits, they, of course, looked at their ligaments. I don't remember. I think it might have been ACL. So they immobilized that ligament that was supposed to be healing for 9 weeks or 12 weeks. And what they found was they had load failure, meaning they would load the ligament and it would tear 29% of the time if they were immobilized for 9 weeks and 31% if they were immobilized for 12 weeks. So that, again, the ligament itself is not the same fibers. And that especially is true where the ligament is attaching to the bone. So that can be bad. So what they find is if you immobilize for something like 9 weeks, it actually takes 12 months of remobilization. So 12 months of moving that ligament in a good way to get it back to normal strength. So it can go back, but again, the idea of immobilization is really, really a bad idea for ligament healing. I love this study. This study came out, I think, 2017, yeah. This study looked at rats, so again, not people, and they did different amounts of immobilization. So they did an immediate mobilization following a surgery, and then they did mobilization after 5 days, after 10 days, and after 21 days. These are pictures of what these different ligaments looked like, and you can see the difference, I think, in the tissue. I think it's very, very obvious here, and that's why I like this. So group 1 was the one that they mobilized immediately, and you can see that the color is different. It's red. There's probably a good amount of bleeding that went on because they mobilized so early. And then you see that B was after 5 days, C was after, how many days was it? 10 days, and D was after 21 days. And you can see, again, that the fibers are very different and that B actually looks the best. And what they found is that the 5 days of immobilization was sort of the lucky number. That those patients, or those rats who started moving at 5 days had better strength for their ligament. They had increased bone formation around the ligament and decreased fibrous tissue. So again, the authors say that A, where they did mobilization immediately, probably led to inflammation in the ligament area, and that's why it didn't have as good of a quality of the ligament afterwards. But I think this is a nice visual so that you can say, okay, this is the difference of immobilization with these different rats and these different ligaments. And again, B is definitely your strongest ligament after being immobilized for 5 days. So I think 5 days is a very appropriate amount of time to consider starting to move something after they've had a surgery and a graft inserted. So we want to start working on restoring range of motion. There is going to be inflammation that is occurring for 48 to 72 hours following surgery, following injury, right? So ankle sprains too, where there's a grade 1 or grade 2, so there's no surgery. And so you really want to wait, again, 5 days if you can, and then start doing range of motion exercises. And you should be doing these for up to 6 weeks, but the idea is that you're not increasing pain. So you want to be doing ankle range of motion after an ankle sprain starting at day 4 or 5. And that will help to develop a good ligament, a good pattern of the ligament. So you want to just make sure that the patient understands that movement is good. And after 6 weeks, they can start doing more stretching exercises. But you need to wait at least 6 weeks so you're not overstretching and overstraining the ligament, because the ligament won't be able to hold up to that. Okay, so you want those collagen fibers to be better developed. Again, we said that takes 6 weeks. And once that 6 weeks is up, then I can start stretching. So if you wanted to, let's say, stretch the ankle into inversion, where you're putting stress on those lateral ligaments of the ankle, that's fine to do it as active range of motion. You don't want to consider doing passive range of motion at end range until after 6 weeks. Remember, we talked about the nerves at the ligament. Basically, we want to make sure that we are trying to get as much of the nerve growth as possible. Those mechanoreceptors in the ligament are very, very important at all ligaments. They help with basically allowing for stability, and then they also help with dealing with the forces so that it doesn't tear again. So there are lots of ways to restore neuromuscular control. We talk about balance stuff. We talk about what's called rhythmic stabilization. So you can put them on one of those little vibrating discs. You can do plyometric activities, different types of perturbation and agility drills. Those are all going to help with restoring that neuromuscular control. You're going to go from low force to high force and low and slower speeds to higher speeds. So you're kind of working your way along that progression. Unfortunately, even when we do all of this, when they look at ACLs, again, this is the one they're focused on, they don't necessarily completely re-innervate. So we don't get nerve throughout like we had before an injury. However, I think we know that nerves regenerate very, very, very slowly. So it usually takes about 24 months to be able to see full innervation. So again, 2 years before we have full innervation of a ligament that's been grafted. So physical activity, how helpful is it? It's very helpful, you guys. So this is why when we're talking about time frames, this is very different than what you're seeing, unfortunately, with a lot of your surgeons in China. And we need to educate as much as you feel comfortable to help them understand how important it is to get full range, to do range of motion exercises early. We want to add some low load, prolonged stress to help make those ligaments heal correctly. So you can do 1 hour a day of just holding in a gentle, low load position of stress. And you just like the picture that you see here. So after an ankle sprain, putting them into inversion very gently, don't stretch past their active range of motion, and holding that for up to or about an hour a day can help to develop a nice ligament. So good. It's important that we're doing active range of motion, but we're not pushing it too far into a stretch. So 5 degrees or more per week is appropriate for range of motion. And that's, again, we're doing that with this low load kind of stretching situation. We also want to recognize that we should not be turning on muscles that work against the ligament, so what we call antagonistic muscles, until maturation and remodeling has occurred. So again, after about 6 weeks, we can start putting more stress strain with muscles on those ligaments. Ligament healing, again, you guys are starting to see these synthetic ACLs in your clinics. That's a very new idea. What other things are happening with research related to ligament healing, platelet-rich plasma, or PRP, becoming very, very, very popular. And basically what they do is they take blood, and you can see sort of the picture here. They take blood in a centrifuge and they pull out all the platelets as much as they can. And so they basically are decreasing the liquid and really increasing the platelets within that blood. And what they find is that this increases collagen synthesis. So this is something that they're starting to use or consider using to help ligaments heal more quickly. This stuff that they've tried this on different ligaments, and some ligaments it works better than others. ACL has pretty good results, but things like the ulnar collateral ligament, which is the last thing we're going to talk about with this module, the results aren't as good. The best results that they found for PRP, or platelet-rich plasma, is actually with tendons. So when Paul talks about tendons, he's going to talk about this a little bit more. There is better research to show that it helps tendon healing than for ligaments. We also are seeing different types of growth factors being used to stimulate the cell proliferation. We have a very famous baseball player who got in trouble years ago because they injected growth factors into his UCL, that ulnar collateral ligament, to help to get it to heal faster. And they said he was using growth stimulating hormones. Well, he was, but he was doing it to help get a ligament to heal more quickly so that he could go back to work, basically. So it's kind of a slippery slope a little bit, but it does work. They do think that it allows for a better ability to bring in cells after things like ACL reconstruction, or in this case, it was the UCL. They're also finding ways to just engineer new tissues. So they're developing these matrix, where it's essentially like a scaffold, and then they have these human cells that grow into the scaffold, and they're using that. So there's a lot. This is kind of a picture showing this scaffold idea, and once they can build these things, then they're trying to use them for things like an ACL. So again, this is probably what you guys are seeing a little bit more here than they are in the West right now, because they're still using a lot of allografts and autografts, but you guys will be the ones who are using these types of tissues. So let's just do a quick summary, a little review of things to remember. Remember, ligaments are bone to bone. They're primarily there for joint stability. If you're working with patients who have a strained or a torn ligament, we're focused on the movement coordination pattern, which a lot of you guys who have taken all of our USC classes, you know patterns. You have to strengthen everything around that ligament if there's some sort of injury to that ligament, and make sure that they have good proprioception, good balance, those kinds of things. We discussed a lot of things with the anatomy. What's the most important to keep in mind is that we want those fibers to be parallel to each other. And that's how the original ligament looks. The original ligament also does not have great blood flow. So keep that in mind, because this healing process is slow. And that's what we talked about related to the ACL. Remember that they're not going to have the ability to have those nice straight fibers the way that it did before the injury. But by performing exercises, range of motion, some manual therapy that puts light tension through the ligaments, the fibers can line up better. So we get a better looking ligament. So you want to make sure that we're allowing for that low load, low tension to happen. After 6 weeks, remember now we're into the maturation phase, and we can start doing more stretching, passive stretching of the ligaments to, again, allow for those fibers to line up. But be careful that you don't do too much for 12 to 16 weeks after that. So again, 3 to 4 months after the first 6 weeks, you can start stretching, but you still have to be very, very careful because that ligament is still healing. Okay, so those are a lot of time frames, but again, this is for all ligaments, which I think is helpful. And so once you kind of have those time frames in your head, then you can really help your patients, educate them, help them understand that tissue is tissue and it has to heal at a certain rate. And there's nothing we can do but follow that rate, and at the same time, make sure that we're doing mobilization of the joint where that ligament has been injured and maybe repaired.